Okay, numbers of participants are stagnating. Then we can start the webinar. Welcome from my side to this ANS spine section webinar. Welcome back for everybody who's been already for previous webinars. Good to see you again. We're having as a topic tonight the topic of degenerative cervical myelopathy, and I'm very happy to have two known experts for this disease or this pathology tonight with me. We're going to have two presentations. As always, during those ANS webinars, those presentations are recorded and will be available via the ANS Academy. So whenever you miss something during the webinar, you can come back and look it up and look for more details in the recorded webinars on the ANS Academy. Whenever you have questions, please use the Q&A box or the chat, and I will ask the questions to the both speakers we have tonight. And we first will have those two presentations by the speakers, and afterwards we'll have one discussion block together for both presentations. Now, coming to the speakers, as already said, I'm very happy to have two specialists for degenerative cervical myelopathy tonight. And our first speaker is Mark Cotter. He's a neurosurgeon from Cambridge, UK, and he's a specialist on neuronal regeneration. In addition to his MD degree, he holds a PhD degree on neuronal regeneration, and his research focus is regeneration in spinal cord injury, and he's heavily involved in research of degenerative cervical myelopathy. He's going to give the first presentation, which is on etiology, pathophysiology, and clinical research. And afterwards, we're going to hear a presentation by Giuseppe Barbagallo, which I'm going to introduce then. But first presentation, as said, Mark Cotter. Mark, thanks for being here, and we're looking forward to your presentation.
Thank you, Florian, for the kind introduction. Let me just bring up my presentation. It's a real privilege to be on this panel and to talk about my favorite subject, which is degenerative cervical myelopathy. And here are my disclosures. This is a condition that is caused by quite a range of pathologies of the spine, as you know, and all of these converge to a syndrome that we call myelopathy. We think it's common, but actually the data isn't very strong. The last estimate is that about 2% of the adult population might be affected by this condition. Of course, there are various degrees of this condition as well. We see progressive cases when we operate on patients, but frankly, the natural history is not very well understood. Another thing that we might not be fully aware of is the extent of how devastating this condition is. Objective measures of quality of life, so SF-36 scores measured across various conditions, show that DCM ranks amongst the worst of all chronic conditions. So it might not look as bad as a spinal cord injury from the outside, but from the inside, it does affect one very severely. Maybe why are we calling this condition now degenerative cervical myelopathy? When you look back into the history and into the literature, you see a lot of different terms that have been used to describe more or less the same syndrome. And of course, that causes confusion, but also causes confusion not only amongst the general public, but also other specialities. And it's actually quite difficult to synthesize the literature that has been published on this condition. So one of the things that Recoding DCM, which was a large multi-stakeholder initiative, tried to tackle is to come up with a name for the condition that we can use more broadly. Apart from the name, we also created a minimum data set, and we also involved patients to come up with research priorities. This was a large initiative, as I said, about 430 people, 68 countries, 17 specialties. And it was a very rigorous process in which we reviewed the literature, conducted interviews and surveys, and then essentially settled on the term DCM, which is also the choice of patients. So going forward, I very much hope that we can use DCM. The initiative also looked at what are the research priorities, and these are listed here. Today, I'm going to cover the natural history and etiology, some of the biological bases, and some of the novel therapy sections. So what do we actually know about the natural history of DCM? Actually, we know that some individuals remain stable over prolonged periods of time, and another proportion of these deteriorate. And often it starts with a subtle deterioration that accelerates. And the third thing that we know is that recovery following surgery remains incomplete. The pathology, we know the fundamental aspects of pathology since the 1950s and 60s. This is not a subtle condition. If you look at the spinal cords here, you can see degeneration of white and gray matter tracts. There are areas of cavitation. So this is a very serious injury that happens over time. More granularly, we also know that it doesn't only affect axons, but also myelin sheaths and also the neurons that live in the anterior horns. And finally, from large animal studies, we know that this condition is associated with some sort of vascular deficit that we really don't fully understand yet. In 2017, we went and did a systematic review of all science papers, basic science papers that have been published there. And the astonishing thing was there were about 50, actually there were exactly 50 papers that we discovered. That is in contrast to about 10,000 papers that were published in the traumatic spinal cord injury literature, which by all accounts is a very rare condition when you compare it to DCM. So what people have found is that there are glial responses, there's apoptosis, there's inflammation, and really we are just at the very basic, the start of this understanding. You might think it's actually quite easy. It's a mechanical injury that causes these symptoms. I need to disappoint you. It seems to be much more complicated. Just a few facts. When you look at cross-sectional studies that look at the prevalence of spinal cord compression, you can see that this is a very common feature. And in fact, of course, it increases over age. At the age of 80, about 80% of us will have cord compression, but only about 10% will develop symptoms. So will develop myelopathy. So it's not a direct relationship. The second thing that is becoming more and more clear, that actually the amount of compression that we see in our clinical patient cohort does not correlate with disability. So you can have individuals with relatively mild compression having severe myelopathy, and others with relatively severe compression that have very rare symptoms, very minimal symptoms, like the one on the right. This is a patient that only had some tingling fingertips. So how can you reconcile this? How can you explain that divergence? One question you could ask is whether there's any kind of particular pathology in the spine that is more likely to cause DCM. And what we did here was we looked again at cohort studies, did a systematic review of those, of individuals that were healthy, and compared the pathologies with the pathologies that are found in symptomatic groups. So here in gray, you can see the various different spinal pathologies that we found. Includes congenital stenosis, Klippel-Fein syndrome, there's multi-level disc pathologies, single disc pathology, etc., etc. And then when you look at these symptomatic cases that were included in the AO International and in the AO Northern American myelopathy studies, you can see enrichment of certain pathologies. In particular, enlargement of the ligament flavum was overrepresented. OPLL, massively overrepresented. So you see a very small proportion in the cohort studies, and then but 26 times overrepresentation in the EO studies, and also multi-level degenerative disease. All other parameters were actually very similar. This does not give us an answer to our question. So it doesn't look like this drives, this can explain the divergence. So what we think, we have to rethink our concepts of DCM. And we did this together as part of this Recode myelopathy project. And here I'm going to propose a new framework that allows us to investigate the biological basis of DCM. So the proposed model is really here. It's a function of DCM is a result of a function that encompasses mechanical stress in the spine that is sort of exerted on the spinal cord, the vulnerability of the spinal cord, and the time that it takes to develop the condition. And if you think about it, all these different pathologies that are compressing the spinal cord translate into really three aspects of mechanical stress. Number one is compression. But interestingly, when you model the spinal cord from a physical standpoint, it behaves like a gel. So the compression is actually only a transient increase of tension or stress in the spinal cord, and then it'll settle. However, when you look at tension and shear stress, you can easily see that this is something that's going to be recurrent every time, for example, we move our heads. The spinal cord goes up and down, and the ridges, the areas of compression, will exert tension and shear stress on the spinal cord. So probably these are important drivers of this. This stress is what we call a trigger. It's not the cause, because it doesn't directly translate into the injury that we've seen on pathological sections, for example. There are two modulating factors. One of them is what we might call the resistance to injury, which might be different from individual to individual. And here on the right, you can see a study that we published recently, which looks at autophagy in spinal cords of individuals that suffered from various degrees of DCM symptom severity. And here you can see the more impaired autophagy was, and that's related to an expression of a protein called BCL2, the worse the symptoms. And you can also see a significant difference in the levels of autophagy between severe and mild individuals. So resistance is one component. The other component that was pointed out in the study here in the 1960s was that there's evidence of remyelination, the restoration of myelin sheaths. That can only occur when myelin sheaths are lost and phagocytosed. And then these thin shows that there's an ongoing process of repair. So resistance and regeneration will then ultimately determine the level of injury. And then this injury still needs to translate into symptoms. And that's not linear either, because there are compensatory mechanisms that even involve cortical layers of the brain that might help to sort of make due for some of the axons and neurons that are lost as part of the condition. So we need to think about this vulnerability in a much broader term. And one way of looking at this is, for example, genetic basis. Here again, this is the output of a systematic review that we've conducted, and we found really two gene groups that are enriched in DCM. One group is really mainly related to genes of the connective tissues, and these are highly associated with OPLL. On the other hand, you can see a set of genes that are much more associated with what I would call spinal cord disease. And one of the main central drivers here is ApoE, which we also know, of course, from other conditions like TBI. So here we've created a framework that looks at aging and genetics as the main drivers, but encompasses all many other aspects that might influence this vulnerability of the spinal cord. A lot of research still needs to happen before we can get closer to this, but we also need to obviously think about how we can improve outcomes in DCM. And one of the things that has been a recurring theme in the last decades is whether the surgical approach makes any difference. More recently, we found a very interesting study that compared anterior versus posterior surgery in a randomized control trial, and the outcome of that is it actually doesn't really seem to make much of a difference. Another area of controversy and widespread differences in surgical approaches is, of course, the posterior surgery, and in particular the question whether we need to do a laminectomy in addition to fixation, or whether laminectomy alone is sufficient. Here, this is some data that we analyzed as part of the EU Spine North American International Studies. And this is a study that had a very low number of patients undergoing laminectomy only, as compared to a very high number of individuals that had underwent a laminectomy and fixation. And nevertheless, if you look at the statistics, you can see that there has been a very strong difference between the two cohorts. I think this is therefore worth a hypothesis that merits further investigation. And really, what we have initiated this year is our Polyfix trial, which is a randomized controlled trial where we randomize patients either to laminectomy or laminectomy infusion. Follow-up is centralized and via telephone. The main outcome measure is the MJOA scale, and the investigator, so the person that asks the patient, is not aware of the surgery that they've received. We're very interested in adding to our network, and it might be a bit difficult to go beyond the UK with the current set of funding, but I would be very excited to actually spread it a bit further. Now, beyond surgery, what are the novel treatments that are on the horizon? And of course, that is a research priority also in that the patients and the Recode project has formulated. We've reviewed this, and really you can classify three different approaches: neuroprotective approaches, neuromodulation, and neuroregeneration. And just what's the difference? So neuroprotective treatments try and halt or delay DCM symptom progression. Regenerative treatments aim to restore function, and modulation, you could say, is symptomatic treatments that try to provide symptomatic relief. Here's an overview of the various different things and technological readiness levels. I will comment on two. A recent trial that looked at riluzole as a neuroprotective drug, and also a neuroregenerative treatment paradigm. So let's start with the CSM Protect trial. This was a trial that was headed by Michael Fehlings. And what they found, unfortunately, is that the primary endpoint, which was the MJOA score, was not met. So riluzole did not have an effect on function. However, when you look a little bit deeper, it does seem that there has been some treatment effect on pain, particular neck pain. However, the study wasn't powered to identify this. Our own studies in the past looked at the biological basis of regeneration. Why do we actually see improvement after decompression? And is this correlated to any changes in the spinal cord? And for this purpose, we used a rat model of DCM. You can see here introducing pressure with a thin polyamide that expands over time, induces a reduction of the motor score. And here, this is the time point when we decompressed. You can see, similar to the human condition, a mild improvement that doesn't really reach baseline. And the major finding here is that axonal sprouting and connectivity seem to be one of the main drivers for this recovery. On the other hand, I already mentioned the human postmortem study that showed that remyelination is also observed in the context of DCM. So interestingly, both processes, axon outgrowth and remyelination, are controlled by similar molecular pathways. And in particular, MAP kinase signaling that you can influence using phosphodiesterase 4 inhibition. And there's been another study that also that tested another phosphodiesterase, and phosphodiesterase as number 3. And they found that in a similar model, treatment with a phosphodiesterase 3 inhibitor actually prevents the generation of symptoms. So we tried to see whether we can reconcile this and formulate a trial hypothesis. And what we found is this drug, which is called Ibudilas, which is actually combined phosphodiesterase 3 and 4 inhibitor. It's safe. It's been licensed in Japan for stroke for 20 plus years. And it's now being developed for a number of conditions in neurological conditions in various clinical trials. So the trial hypothesis of receipt myelopathy is that Ibudilas will improve neurological recovery following surgical decompression. And this is a classic randomized placebo-controlled trial, which uses a pragmatic inclusion criteria with individuals with moderate to severe DCM, with confirmed compression on the MRI and obviously confirmed clinical signs and symptoms. The patients are randomized to 2 arms, and they start treatment before surgery, hold during surgery, and then continue treatment for another 6 months. This trial is started. We've just finished the pilot study, and we can already record safety. So it seems to be very well tolerated, and I'm very much looking to expand this. We not only use the MJOA score as a clinical outcome measure, but also a second clinical outcome measure as a co-primary endpoint. And this was something that we learned from our patients. So if you look at a patient survey that we've conducted, what the main outcome or recovery priorities are, you can see number 1 outcome priority is pain. That was something that I really didn't expect, and there was not much mention of pain in the literature. And the other one, of course, are functional outcomes that are summarized broadly in the MJOA scale. Now, why do we think that pain may also be conducive to modulation with a regenerative drug? Because a lot of this pain component seemed to be related to neuropathic pain mechanisms in the spinal cord, and this is just an early literature that's emerging. So the study has a co-primary endpoint, and will be positive in any of these endpoints are reached. As I said, we started the trial, and we're looking to roll it out to other centers in the coming year. And with this, I'd like to say big thanks also on behalf of the Recoding DCM project, and look forward to further questions.
Well, thank you, Mark. Excellent presentation. Very nice. Very good set of new information. So as said in the beginning, I would like to move on with the other presentation, but Giuseppe talk about the surgical approaches and surgical indications before we have a discussion together after both presentations. So our next presenter is Giuseppe Barbagallo. He's a neurosurgeon, professor of neurosurgeon at Catania University in Italy. And as Mark, he's a very well-known expert on cervical myelopathy. Has been heavily involved, or is heavily involved in ongoing studies on cervical degenerative cervical myelopathy, among others, also in the important AO spine studies. And he's going to talk about the indications for surgery and the selection of best approach. We already heard about some aspects of posterior versus anterior, and Giuseppe is going to extend this discussion on the best approach and the indication for surgery. Giuseppe, I'm looking forward to your presentation. Thanks for joining us.
Thanks, Florian. Thanks for the invitation. I think Mark gave us some very important information and a view, I would say, in the a step in the future. So this is my conflict of interest. And first of all, when we talk about the degenerative cervical myelopathy, we all know that we are facing completely different or somehow different conditions, as we can see in these pictures here. And so the point is, what can we do for these patients, and why should we do something rather than something else, and when should we intervene? Now, we know that at least 1 in 50 people may live with cervical myelopathy. Mark already showed this data. There is a significant percentage of people who do have spinal cord compression and MRI, about 25%, but only 10% of those are going to develop cervical myelopathy. Now, if we go back to the literature in terms of what I call bread and butter, which means, clinical everyday practice, we know since at least 10 years, I should say, from some of the studies which have been conducted by Michael Fillings and his group, that the surgery does have a role in getting patients better. And as you can see here, these are the results also from the international AO spine study. And so Fillings in 2015 pointed out that surgery is increasingly recommended as a standard treatment for cervical myelopathy, degenerative cervical myelopathy, or at least it should be increasingly recommended. But we should also consider that for many years we have been told, and we have grown with the idea, and we have been telling patients that surgery, the main goal of surgery, was to halt neurological deterioration. Actually, maybe we should change our attitude, and we should start considering that surgery can actually improve the neurological function of our patients. So how do we assess our patients? If we think in terms of indications, how can we decide for which patients surgery is indicated or other forms of treatment could be advised? The gold standard should be to use the MJOA, as Mark already pointed out. And we all know that there are different grades of involvement, of clinical involvements for these patients. So the other point, which I really think is extremely important before taking the final decision on whether to do surgery and what type of surgery we should do, is to have a thorough imaging evaluation of our patients. I strongly recommend that X-rays, including flexion extension views, should always be performed and can always give us a lot of very important information, as you can see here. I also value a lot the CT scan, and in few patients, even myelography can still give us some information, some important information. There is also something else which I also think adds some value, which is the kinetic MRI. If we look at flexion extension MRIs, which is a simple test which can be carried out in all of our departments, actually, we can even more get important information, and we can also get very useful data to counsel our patients before surgery, as you can see in these pictures here. If we go back to this quite interesting systematic review, which was published in 2014, and you see several papers, several articles were reviewed, And the bottom line was that kinetic MRI is effective for diagnosing, evaluating, and managing degenerative disease within the spine. However, when we are left with severe myelopathic patients, kinetic MRI can be a problem, and not always we can perform this type of investigation. So if we wonder about the guidelines, what we are left with in the literature at the moment in terms of guidelines to take a decision for cervical myelopathy, we can go back to this very interesting paper, which was produced once again by a very respected group of colleagues headed by Michael Fillings, published in 2017. That's an EOS-1 study. And this study gives us important information. If we are dealing with a patient whose MJOY is less than 12, which means severe myelopathy, then surgery seems to be recommended. When we look at the quality of evidence and the strength of recommendation, and I would advise that you pay attention to this data also in the next slides, you can see that, that we are dealing with a moderate quality of evidence, but a strong recommendation. The strength of recommendation is quite strong. If we are dealing with a patient who has a moderate degenerative cervical myelopathy, once again, what comes up from that study is that surgery again should be recommended. Things tend to change when we are dealing with patients with mild myelopathy, because in these cases, we can opt either for surgical intervention, or we might select patients for a supervised trial of structured rehabilitation. So here we are moving into a field, into an area where we have to be careful when we counsel our patient and we advise patients on what they should be doing. Another problem, if we are dealing with patients who are non-myelopathic, but who have imaging evidence of cord compression, and they also have clinical or electrophysiological evidence of radiculopathy, what's our recommendation? Well, again, we can offer surgical intervention, or we can also offer these patients a supervised trial of structured rehabilitation. This is interesting, even more interesting maybe, because this is what I like to call bread and butter in everyday practice. Non-myelopathic patients with imaging evidence of cord compression, but without clinical or electrophysiological evidence of radiculopathy. Then in these patients, we should not most likely, or we should not advise any surgery, because it seems that there isn't a role for prophylactic surgery. We should educate patients, we should tell them what they should be careful about, and we should follow up them very closely. What about if we are dealing with patients having a cervical deformity? Look at these patients, MJO of 70 years old lady with severe myelopathy. Then the question for us is, should we correct the deformity, or should we only perform decompression and maybe just an in situ fixation? Well, there is evidence in the literature coming from many years ago that increased sagittal malalignment increases cord tension, flattening, and reduced cord perfusion. So we have to be very careful. On the other hand, look at this paper. This was published in 2015 in France by Jean-Charles Lewec, and he pointed out that 1/3 of patients, asymptomatic patients, do have cervical kyphosis. So again, it seems a confusing data, a confusing element, but I think we should be very careful when we are dealing with a patient showing deformity. And then we move towards what I call the evergreen questions. So, many times we have wondered, is surgery effective for degenerative cervical myelopathy? From what Mark said, from what I already showed you, the answer should be yes. But what is the long-term outcome of surgery? And then when we try to answer this question, there are also other questions we are left with. What is the effect of severity of myelopathy, age of patient, duration of myelopathy? What is the role of intramedullary signal changes on MRI? And once again, what's the role of the surgical technique that we are going to use in terms of outcome for the patient? So we have to remember that the goals of surgery are relieve the compression of the spinal cord and nerve roots, stop the progression of the disease, and as we already said, now our new attitude should also be that the goal of surgery should be to improve neurological function. So which are the criteria to choose our surgical approach? We should, of course, consider the site of compression. If we are dealing with an anterior or a posterior compression or a 360-degree compression, what's the extent of compression? And in this perspective, we also have to consider a slightly different disease, what my friend Claudius Tomé calls a different animal, which is the OPLL. We have to consider the spinal curvature and the sagittal balance, the stability of cervical spine, and of course the surgical technique, and I would also say the surgeon. So what about the site and extent of compression? Classically, we have been trained in understanding if we are dealing with an anterior or a posterior compression, and even more importantly, if we are dealing with a patient harboring a compression at 1, 2, or less than 3 levels or more than 3 levels. And maybe, in these cases, things and decisions might be different. Another element which really deserves attention is the spinal curvature, because Professor Benzel, many years ago pointed out that this has a key role, the curvature of the cervical spine has a key role in what will happen after surgery. These 3 patients are totally different patients, although all of them are still harboring degenerative cervical myelopathy. And the literature, once again, comes to help us because there is evidence that if we are dealing with a sagittal imbalance, which is defined as a C2, C7 SVA greater than 40 millimeter, then we may have a worse postoperative outcome, a worse postoperative SF36 score, with less than 50% of patients improving clinically after surgery. And this is important to remember, particularly if we are thinking to undertake a dorsal posterior surgery, as you can read here. What about indication to surgery? For instance, for the anterior approach, we know that there are different options. We may deal with ACDF, even at multiple levels. We can deal with corpectomies or hybrid techniques. And when we mention hybrid technique or techniques, we should remember that there are different combinations of different techniques. Now, anterior approaches and multi-level ACDFs. We have been using these techniques since a long time. Like many other colleagues, we think that we can actually achieve a satisfactory neural decompression. If you look at the red arrows here, you can actually see that you can decompress quite adequately the spinal cord, even going up and down in the posterior part of the vertebral body, and this can be quite helpful. When you look at the follow-up of these patients, you can realize that even if you lose a bit of lordosis, which you gained initially, still patients can be doing quite well in terms of clinical outcome. And also when you try to assess the rate of fusion at multiple levels, this seems to be quite satisfactory as well. When we move towards hybrid techniques, I still think that this is something doable, even in myelopathic patients, particularly when you're dealing with patients who do harbor different disease at different levels in the cervical spine. So you can actually combine during the first operation, the index surgery, arthrodesis and arthroplasty at different levels, as you can see in this picture. And I still think that this is a good way to respect anatomy, to respect pathophysiology, and to avoid long segment fusions. Many years ago, we tried to come up with an algorithm which helped us in deciding at which level we had to perform an ACDF and at which level we had to perform a TDR, an artificial disc replacement. But when we think about, for instance, more extensive pathologies, and we discuss about corpectomies. Then the question is, should we always deal with corpectomies or also at multiple levels? Or we can use different strategies, different techniques. And I would like to draw your attention to this other option, which again is a hybrid technique, which was published in 2005 by our Israeli colleague Ashkenazi. And he proposed to combine somatectomies with ACDF at different levels, as you can see in these pictures. And the rationale behind this strategy is that these implants, these hybrid techniques, preserve more the spinal integrity, reduce the number of bony surfaces to fuse, increases torsional resistance, and is a technique which is indicated in elderly patients with osteoporosis or poor bone quality. As you can see in these patients, of course, you can face other issues like adjacent segment degeneration or adjacent segment disease, as you can see in this patient. But again, it seems to be a good option. Now, I think something which can be really interesting when we have to take a decision is considering the different techniques. So if we still among the anterior approaches, so if we compare, for instance, ACDF with corpectomy at multiple levels, 3 or 4 level ACDF or corpectomy, what you can see here is that ACDF seems to be better than corpectomy infusion for blood loss, lordotic curvature improvement, and complications. So actually, as you are going to see in this study, in this slide, it's important to consider that we, as we said, we can use different techniques. We can use ACDF at multiple levels, we can use corpectomies at multiple levels, or we can use the hybrid technique combining corpectomies and ACDF. It is important to understand that if the compressive pathology is at the disc level, this can be resolved by discectomies, ACDF, even at multiple levels, and ACDF remains the treatment of choice. The hybrid technique is an ideal alternative to ACDF if we have to deal with retrovertebral pathologies. Those pathologies, those compressions which are just behind the mid portion of the vertebral body. But these authors, more than 10 years ago, came up with a conclusion that corpectomy and fusion was the last choice to be considered because of complications, because of the rate of pseudoarthrosis. When we move to posterior approaches, then things change again, and Mark already gave us some information. The key point is, shall we use simple laminectomies? Shall we use laminoplasties or laminectomy and fusion, posterior fusion? This is another interesting paper. A few years ago, it was published, and the results were that multi-level laminoplasty and laminectomy and posterior fusion are both safe techniques and both are effective as procedures, and they are associated with low morbidity for our patients. And most likely patients, as Mark said, who underwent laminectomy and posterior fixation had better neurological outcomes compared with those patients who had only laminectomies or laminoplasty. Even Michael Fillings, once again with his group, a few years ago, came up with similar results. Apparently, there were no very important statistical differences between the two strategies, the two techniques, but laminectomy and posterior fusion seems to be a very good option when we are dealing with patients with severe neck pain or with loss of lordosis, with kyphosis, or of course with patients who are showing instability. If we have to deal with patients with OPLL, again, as I already said, this is a different disease, different pathology. And when we compare the two possible options, which are corpectomy from the front or laminoplasty from the back, again, corpectomy is recommended for those patients who have an OPLL causing preoperative canal occupation or occupying ratio superior to 60%. If we are dealing with patients with OPLL but less than 60% of canal occupying ratio, then a posterior approach again is a good option. What about the circumferential approach? It's another key issue, because there are surgeons trying to perform circumferential approaches very frequently, and others totally ignoring this approach. I think this paper was published many years ago, but still I consider it a landmark paper coming from our colleague Pravin Mumameni in San Francisco. And it's a very important paper because it highlights the role of sagittal profile. It tells us that we have to consider the number of stenotic segments. If we are performing more than 3-level corpectomies, then we have to consider a 360-degree approach. We also have to consider, the site of cord compression and consider where the spinal cord is compressed and by what or by which cause the spinal cord is compressed. We also have to consider metabolic factors. If our patient is osteoporotic, is diabetic, if he or she is a smoker patient. Age, neurology, and general conditions are important items, important issues to be evaluated as well. And of course, we have to consider what we can do with our hands. So this is a simple example. If you are dealing with this severe deformity and severe compression, and you can see, X-rays and CT, then of course, in these cases, we prefer a 360-degree approach because it's important to decompress everything, and it's also important to reconstruct and guarantee the patient, an acceptable sagittal alignment, as you can see here. So coming to the conclusions, we already saw this paper. This paper confirms that surgery has a role for sure, and some colleagues or some surgeons always raise their hands saying, okay, but which is the price that we have to pay, or which is the price that patients have to pay in terms of complications? Well, there might be, and there are complications, perioperative complications, but patients have a higher risk of complications if they have a greater number of comorbidities, if there is a coexisting diabetes mellitus, if they have OPLL, and if surgery is going to take a longer duration than usual. So in conclusion, I think that CSM is a progressive validating pathology requiring careful clinical and even imaging workup. We have to seriously and carefully consider the site and extent of compression, the spinal stability, and the sagittal profile. Please be careful about also deformities, because all these are key factors to be considered before choosing the approach. I still think, even if going back to the literature, that the anterior techniques hold value in most of our cases, particularly if we use all the spectrum of anterior approaches which are available, allowing direct neural decompression both at the disc level and behind the vertebral body. And the anterior techniques can really help also in restoring the sagittal profile. Of course, Mark gave us a very important overview on what the future research could bring, but we also should come up with new guidelines and more evidence-based medicine. And at the same time, we have to consider that all these guidelines always have to be tailored to the single patient that we are treating. Thanks for your attention. And Florian, back to you. Thank you.
Thank you, Giuseppe, as well. Excellent presentation, excellent overview. Now we have time for some questions. Now, I would like to start with a question to Mark. Mark, you showed in the beginning of your presentation that a certain subset of patients is asymptomatic despite they have a significant cord compression, and that a subset of patients which is symptomatic remains stably symptomatic, not declining, and another subset is going to decline. What's the proportion of patients who are symptomatic that will decline, and what the proportion of patients which are asymptomatic and they're going to decline, and what predictors do we currently know which can guide us how we should handle this patient?
I mean, that's a very important question. It's actually the key question that we need to address to really make a big dent in outcomes of DCM. So what the numbers suggest is that about 10% will develop DCM, whilst 90% won't. That's based on MRI cohort studies and summarized in one of our papers. The question of what proportion of patients will deteriorate when they have mild DCM is also subject to various investigations. There's a nice paper by Sukhwinder Kalsi-Ryan that looked at mild cohorts, and I believe they found about 60% of patients deteriorating over time. It's a matter, of course, also of the time that you observe these patients. There is still a lot of work to be done in order to nail that. In terms of what can predict deterioration, at this point in time, there's two things that have been identified. I think those are the only two predictors so far. But one of them is if you also have a radiculopathy. So if you are, and that might be that your CNS or and peripheral nervous system again is a bit more susceptible to pressure, because as we know, there's a lot of disc degeneration or foraminal narrowing that doesn't lead to radiculopathies. And the other thing that has been identified is electrophysiology. So changes in electrophysiology can also be predictive.
And the role of a T2 hyperintense signal in the spinal cord, is it any predictor of the course of the patient, of the potential recovery a patient can have? There has been some PET studies looking whether this is already a chronic state of spinal cord damage or whether this is an acute state which is potentially reversible. How is this predictive of the course of the patient?
At the moment, I think the signal change as such is not predictive, and it's difficult to sort of categorize this. The PET study is an interesting one because it looked at FDG PET, which is sort of the activity of the lesion in some sense, and they found an active lesion is more likely to improve. So. I think ongoing pathology might mean that there's active processes that try and resist the degeneration that is caused by the mechanical stress. At this point in time, what we know is that signal change, especially in asymptomatic patients, should not be considered a reason to operate on them.
Okay, thank you. So Giuseppe, there are some questions coming in regarding surgical technique, and one is about your opinion about posterior fixation without laminectomy, as proposed by Atul Goel. I think it was more proposed for the basilar invaginations and carrier malformation, as far as I know. But does it have any role in degenerative cervical myelopathy? And then there's another surgical technique question which refers to midline keyhole corpectomy without an instrumentation, so anterior without instrumentation. Could you comment on this?
Yes, Florian, thanks. Regarding the first question, I think I would agree with you. As far as I know, Atul Goel proposes what many of us do, which is a C1, C2 fixation without sometimes even laminectomy for CVJ malformations like basilar invaginations or retroodontoid pseudotumor or pannus. So in degenerative cervical myelopathy, if there is a spinal cord compression, the first thing that we have to achieve is the decompression of the spinal cord. So honestly, I do not think that's a good idea to only fix the patient and without performing any decompression. So maybe our colleague was thinking about the C1, C2 fixation for other disease. Regarding the question of a keyhole decompression, when I present about C1, C2 techniques, I have one slide where I show one of those cases where I did this, but I think there is a role for these keyhole decompressions only in those patients who already have a natural fusion of the vertebral bodies. So we do not need to perform other fusions. Nature has already provided fusion, and we only need to decompress the spinal cord focally in a specific area. Then you can do that. But we have to remember what Bernard Georges, the French surgeon, was proposing, which is the oblique somatectomy and the oblique decompression without instrumentation. That's a different technique from the keyhole midline fusion. But again, I would leave the keyhole spondylectomy, as it is called technically, only in those cases or for those patients who do have segmental compression of the spinal cord and are already fused.
Okay, then we do have a question about this annoying complication we all know of the C5 palsy. The question is, well, what is your experience now? I'd like to expand the question. Do you have any techniques how to avoid C5 palsies? Do you use anything like going for decompress the root first before you decompress the spinal canal when you go from posterior, or anything like that? And what is your experience? How do you handle it?
Well, honestly, I have tried over the years a couple of different options, but I have not found, the gold solution, I would say. I try to do a foraminotomy when I go posteriorly from the back, but I think it's also related to the traction of the nerve root sometimes. And I honestly, I don't have any specific solution, because I have seen patients with significant posterior shift of the cord and traction of the root without any CSF palsy, and patients who on postoperative MRI do not have significant posterior shift of the spinal cord, and you would assume that that patient doesn't even have a significant traction of the nerve root, but he or she has developed a C5 palsy. So maybe it's also related to the length of the root itself. It's related to the specific to the subject anatomy. But I don't. There are lots of theories behind this complication. There are lots of proposed options and solutions, but I don't have anything magic in my hands to really prevent that. You can even try, as you said, to decompress the nerve root before doing everything, and then your patient comes up with a C5 weakness, even a mild weakness anyhow. So the answer is no. Don't have any specific magic solution.
Okay.
Do you, Florian?
No, I don't have any solution. I try to decompress the roots first, and that there's some publications on doing EMGs prior to surgery, whether this is good to identify which roots are prone to getting a C5, but I've never tried it myself. But I did those decompressions of the root first, but had also doing this C5 palsies in this group of patients. So,
and the other interesting thing, of course, is that anterior surgeries can cause C5 palsies as well, where you really don't think that they're stretched. So, I mean, this is something that we don't really understand at all. There's been this hypothesis of a reperfusion injury, potentially. That's an interesting one. So that, but I think we need to really sort of dig much deeper into this. It's difficult though, because it's rare.
It's rare, but we all know it, and we know how annoying it is, and that there's no really good solution and no good information of how to solve this problem. But there's, Marcus, you just answered this question online in writing, but I think it might be good to comment on it as well. The ratio of clinically myelopathic patients among patients with radiological myelopathic changes, I would think that this is with the T2 hyperintense signal. The question was, well, it's 100%.
No, it's not. It is actually, I don't know the exact number, but it's astonishingly low amount. It's obviously it is high, the proportion of individuals with T2 hypertense changes that are myelopathic is higher than the ones that have cord compression without these changes. But it's not 100%. Therefore, I think actually using the term radiological myelopathy makes no sense. Myelopathy is a syndrome. It's a clinical syndrome, and it has to be grounded in symptoms. I would say cord compression with T2 signal changes is the correct way of mentioning that.
Yeah. I think that's an important point to stress it, as it's tended to be used as myelopathic imaging changes, which is not true.
Yeah.
Okay. But sticking to this imaging, Giuseppe, you mentioned kinetic MRI. How is it included in your pre-surgical decision making? Do you use it? Is it already included? Do you have experience with it? And how would you use it, the kinetic MRI, in a, let's say, mildly symptomatic patient? Does it play a role in an asymptomatic patient? I would guess rather not. What's your experience with it?
Well, Florian, I think you just made the point. The kinetic MRI makes sense in mildly symptomatic patients. When you have patients who are somehow symptomatic, and your standard MRI does not give you what you would expect as an answer, then we ask the radiologist to perform a kinetic MRI, which is easy to perform because we easily use some sort of pillow which is put under the head first. So this pushes the head down and gives neck flexion, and then you put the same pillow under the shoulders, and the neck goes in extension. And sometimes it's interesting, and it's very interesting because you find that things change. If you compare the standard lateral MRI with flexion and extension views, you can actually find that there is more compression. Usually there is more compression in extension rather than in flexion. So when we have patients, for instance, with positive MEPs, or patients who are somehow symptomatic, but imaging classical standard MRI does not fit quite well with the symptoms, then we ask the radiologist to get a kinetic MRI, and sometimes we get more information, and we can have more information. There is also something else. You can ask your patient to spend 5 minutes holding the head flexed or extended, and if the patient, for instance, develops more sensory changes even in the upper limbs by doing that, this is another sign that on flexion extension there might be some changes. So yeah, I think it's a simple test, and does not cost anything more than a standard MRI, but can give important information.
Yeah, I agree. I mean, I often use this, not often, but I use it in the context of a mismatch between clinical symptoms and an absence, quite frankly, of cord compression. You sometimes see flattened cords, but actually in the static MRI scan, you don't see pressure. And what we found is that sometimes when you then go into flexion or extension, you either see embuckling of the ligamentum flavum, but also we've seen disc protrusions in the flexion state, which then explain a dynamic compression, which then allows you to consider surgery in that instance. And the outcomes when you do that seem to be very, very positive. In fact, I think there's one thing that is emerging, and this is not validated by empirically yet, but if there's more dynamic or circumferential stenosis, patients seem to be improving faster after surgery. But that's just a sense that I have, nothing with numbers yet.
And you do it in a standard MRI machine, or is it some special upright MRI, open upright MRI, which are kind of getting more and more, but we don't know about the significance? So you do the standard MRI and have the patient just flexed and extended the head, or?
I think probably an upright would be great because you also have the heaviness of the head that might help sort of squeeze out some mobile disc fragments that shift forwards and backwards, for example. But to be honest, we use a standard MRI. We have a little device that does this and this with the patients, and it's also helpful. I mean, we don't know what we miss by not using an upright MRI scan.
I think, Florian, I would agree with Mark. We also use a standard MRI machine, but I think that the upright machines can give us different information because the head weight and the gravity can actually give more information in terms of changes in the shape of the cervical spine, the sagittal profile of the cervical spine, the cervical thoracic junction. So if we have to evaluate and to assess what the sagittal balance or the sagittal profile of the cervical spine is, then upright machines can really add something, I think. But in terms of getting just a standard kinetic MRI, standard machines are doing the job quite well with no added costs at all.
Correct. I agree with that. Yeah. Mm-hmm.
Okay. Mark, when you described the pathophysiology, you had these points: mechanical stress, and of course vulnerability or resistance to mechanical stress, and the potential of regeneration, which are potentially two things which are somehow encoded genetically. Or would you agree this must be underlying genetics? And and you mentioned those genetic analysis. How do you think this might carry on? How genetics or more genetic information could help? Would you expect some like sequence changes which are potential things for a therapy, or is it just on first hand identifying the patient which is more vulnerable than another patient and which needs earlier surgery than a more resistant patient?
I think the second thing that you just said would be the best thing, that if we could magic up something now. I think if we had a test that we could apply with a patient that has mild DCM and know which one of those would be deteriorating, then we could prevent a lot of injury. So I think the primary objective, my primary driver to look into this is really to have something that helps guide our surgical decision making. And there's really two aspects. I do think there'll be some risk genes that will be emerging. There's a small number at the moment, but this hasn't been studied rigorously at all. What we really need to do is work towards a much more substantive study, like in other conditions. The other thing that I would say, there's another metrics which seems to be gathering a lot of traction in other conditions, such as also dementia, which is the epigenetic state. So this is epigenetic noise, Horvath's clock, etc. And these are single sort of measurements that seem to be predictive for the progression of many other conditions. And that's something we're looking into as well. So this is all very much early stage research at the moment, but I'm quite excited about this. And I hope that we're going to find something.
Okay. So one final question from the Q&A box. We're always told that whenever there's a signal change within the cord, the patient should have surgery as soon as possible. Though this is not true. I would say it's not true. Would you agree? I mean, we discussed this before, and the question has been before whether the signal changes, patient with the signal change is always myelopathic, and it is not, and it should be focused on the symptoms.
Yes, the guidelines are very clear here. It's the symptoms that should guide decision making. Okay,
so we're already 10 minutes or almost 15 minutes after 6. I think that has been two outstanding presentations and very good discussion. Thank you very much for being here tonight and doing this webinar. It has been a pleasure, and thanks a lot. So from my side, this was the last webinar of this year. We're coming back, I think, in January. I'm not 100% sure. I have to clarify this with the ENS office, but you will be informed about any further webinars from the ENS Spine section. Tonight we had a very good number. I saw the maximum number of 118 participants, which is very good. So thank you for everybody who joined us, who has been watching and participating with the questions, and have a good evening. Thanks a lot, and bye-bye.
Thank you.
so much.
Bye-bye.
Bye-bye.
Bye-bye.